Hey guys, welcome back. The topic we're gonna study now is primary biliary cholangitis. When I was a student your age, I used to read this as primary biliary cirrhosis. But the point is, we would like to make an early diagnosis, not let the patient suffer from complications of cirrhosis. So that's why the nomenclature has been changed to the precursor of primary biliary cirrhosis, that is primary biliary cholangitis. Now, why this happens would be the objective of the discussion and the clinical manifestations, and then we're going to compare this with primary sclerosing cholangitis. PSC is what I feel people are more comfortable with. So let's begin with primary biliary cirrhosis, the less commonly studied version. Well, you are all aware that one of the etiologies behind this would be autoantibody by the name of anti-mitochondrial antibody. And while I'm describing this, I want to highlight that lots of time in multiple choice questions, he might be introducing a very similar sounding name, that is anti-microsomal antibody. I hope all of you remember from the endocrine discussion when I have spoken regarding Hashimoto's thyroiditis, we have spoken regarding anti-microsomal antibody. So do remember, because lots of time, due to paucity of time, errors of judgment can be present. One of the highlights of this particular disease on a comparison with PSC that I'll discuss later will be that this is primarily a intrahepatic disorder. In primary sclerosing cholangitis, the problem starts from outside, extrahepatic, then moves on to the intrahepatic area. So you will answer PSC as a combination of intra plus extrahepatic lesions. But when it comes to PBC, it would be intrahepatic lesions. So let's just study what these lesions would be. Well, there would be damage to the cholangiocytes. The textbook will describe the word non-suppurative because obviously we're not talking about any infection, but we are talking about a autoantibody mediated manifestation or damage here. So this would be non-suppurative cholangiocyte damage that will in the long run definitely contribute to cirrhosis. But let's look at what happens prior to that. One of the initial manifestations of these patients will be features of cholestasis. I'll be describing various features ranging from extensive pruritus, which initially might be misdiagnosed also in these patients as maybe a manifestation of allergy, or if a patient is low socioeconomic, you might think in terms of even scabies as well. But subsequently, there would be development of ductopenia. So the severity of the manifestations will increase. From the pathology domain, do remember initially there will be eosinophilic infiltration. There might be even neutrophilic infiltration and then a granuloma formation. The last manifestation that will occur in these patients will be cirrhosis. Once it becomes decompensated, even portal hypertension manifestations will occur. From the MCQ perspective, if they mention regarding micro or macronodular, both varieties of cirrhosis can be encountered here, but your first answer will be given as the way I have written, micronodular cirrhosis. In fact, from the pathology domain, you should also be aware of the stages of progression of the disease, and it's very simple and straightforward. So I'll just make you revise it. Initially, there would be development of this damage, especially the granuloma formation, the cholestasis component, ductopenia developing mainly in the portal area. So there would be portal stage of Ludwig, that would be stage 1. Then subsequently, the same damage will extend. So he will say periportal damage / inflammation. Then subsequent to that, it would be the entire lobule that will get involved. So as the lobular damage progresses, he will say septal damage and then subsequently cirrhosis. This is just to refresh the pathological aspects here. And now let's look at how a patient will present, because we have talked mainly regarding what is the cell that's going to be initially damaged and how the body is going to react to it. From the clinical domain, this disease would be more commonly seen between 40 to 60 years of age, and we'll usually talk about a female patient. Well, I can say just generally speaking, autoimmune disorders are anyway more common in women, but this would not be a young female in the reproductive age group, usually in late 40s onwards. If he says what's the earliest manifestation of this patient, do not answer straight away pruritus, because yes, pruritus is seen. But initially, there's a very non-specific manifestation that develops in these patients. So lots of time you will notice that, they will put up this trick question, what is the earliest manifestation? And obviously, we are thinking from a clinical domain. So we think, okay, cholestasis causes pruritus. So that should be the earliest manifestation. So just a word of caution here, answer it as fatigue, though a very non-specific finding, which explains the fact why it takes even, I would say, experienced hepatologists to identify this disorder. Now, subsequently, obviously, the pruritus component would come up, and this would be pretty severe before the diagnosis will be made. So it is no big deal that you might be noticing scratches over the skin, because the patient is irritated, is not able to sleep because of it, and there would even be lichenification of the skin present. From the exam perspective, therefore, he can ask you here that what is the reason for development of pruritus. Then don't straight away say elevation of bile salts, because it has been demonstrated in clinical studies that when the liver is damaged, there is a increased production of endogenous opioid peptides which are pruritogenic, and they contribute to this intractable itching that is developing in these patients. In fact, the receptors for these endogenous opioid peptides are also upregulated. As a result of it, the manifestations become fairly severe. And as I said, I mean, we initially might think this could be manifestations related to food allergy, or it could be atopic dermatitis. I mean, there would be a dermatological component predominant present in the patient. So I am thinking to myself, I mean, why is it that this person is not responding to the conventional antihistaminics? In fact, lots of time we might have to use opioids to relieve the pruritus component. So I will describe the drug subsequently, but this is fairly an irritating problem in these patients. Things will become easier for you in the MCQ once he starts talking about development of icterus, and most patients on presentation initially will be having hepatomegaly. You can very well relate to the fact that once you go into stage 4 of the disease, once the fibrosis component will come in, once the stellate cells will contribute to fibrosis, then obviously the liver span will reduce and it will not remain palpable anymore. The manifestations of damage to the liver could also be described in the question. That would be palmar erythema. Then you will notice over the superior vena cava distribution over the shoulder and the neck of the patient, there would be these spider angiomas or spider nevi present. Mostly in patients, muscle wasting can also be appreciated, though most of Indian patients are anyway thin and skinny. So it's a little difficult to pick up, but still, if you have seen alcoholic cirrhotic patients or even cases of, because I said alcoholic cirrhotic because that's more common a presentation in our hospital. But if you take up both alcoholic cirrhosis, primary biliary cirrhosis, then you will notice temporal muscle wasting, right, and proximal muscle wasting in these patients. Fairly, on general physical examination, a finding that becomes very obvious, though in a very skinny person might be a difficult one to appreciate. Now, once the cirrhosis component will decompensate, that's when ascites will start developing, caput medusae will start developing, splenomegaly will definitely be present. And the worst case scenario can be that this guy never sought any medical treatment, or he came to the hospital so late that, he might even end up with variceal bleeding as well. So the message is that our objective is to have a high index of suspicion and try and pick up the disease relatively early. Even the lipid profile is deranged in these patients. Because of the derangement of the lipid profile, one of the derangement of the lipid profile, I can say like this: LDL cholesterol is found to be elevated in these patients. Why? Because if the liver is damaged, the receptors for LDL uptake are hampered. As a result of it, once the LDL cholesterol increases, I mean, I can say that even the incidence of heart disease can indirectly increase in these patients. Xanthomas, tendon xanthomas can be present, or over the eyelids of the patient, you might be having xanthelasmas present. So either of the two or both of these could be a manifestation. Most of the time in the initial part of the disease, LDL is anyway elevated. I told you the reason: the receptors for LDL are rather downregulated secondary to the liver damage. And you might find that in the initial presentation, though this is not important from the exam perspective, but I'm just telling you the fluctuation that happens. Initially, HDL values are found to be elevated in these patients, but as the disease will progress, then the HDL values will also begin to reduce. So you can understand why I was talking about the cardiovascular component, or I can say that heart disease incidence can subsequently be increased in these patients because bad cholesterol is more and the good cholesterol values are substantially reduced. Coming to the next manifestation, since these patients will also be having steatorrhea, you see, after all, because of the cholestasis component, the bile is not going to be able to flow as it is normally going to be. And bile is responsible for emulsification of fat. So these patients will be having steatorrhea, and steatorrhea on a regular basis will not only be causing a foul smelling bulky stool, but at the same time there will also be deficiency of fat soluble vitamins. Now, this statement that I'm writing before you, steatorrhea, deficiency of fat soluble vitamin, may not be written. He might just write the word osteopenia, because you know that there are 4 fat soluble vitamins, vitamin A, D, E, and K, and the manifestations of vitamin D deficiency, they develop relatively early, and patients are able to feel that also relatively better. So there could be, bone pain present in these patients. Osteopenia is a feature that is written in multiple choice questions. The reason I have explained, steatorrhea and especially deficiency of vitamin D, though subsequently if the disease remains undiagnosed, even vitamin A deficiency, vitamin E deficiency, especially vitamin E deficiency causing acanthocytes, can even be present. Because this is an autoimmune disorder, so Sicca syndrome manifestations of dry eyes and dry mouth can be present. And what I say next is definitely of concern. I'm using a different color to highlight this. You see, KF ring is very, very specific for Wilson disease, but then KF ring is not 100% confirmatory for Wilson disease, because it can be seen even in patients of primary biliary cholangitis who progress into primary biliary cirrhosis. So just highlighted it, though KF ring per se, I want to highlight, is a rare manifestation of the disease. But because it is rare from our exam perspective, because they love to ask about the relatively less common presentation as well. So we need to remember this. The learning for us is a woman in her late 40s is having features of cholestasis, went to dermatologist multiple times, no relief. Then when she came to physician, we picked up icterus, there was an enlarged liver. If she came late, there's going to be features of portal hypertension, there's going to be steatorrhea secondary to the fact that bile responsible for emulsification of fat effect would be gone. Some autoimmune manifestations can also be present. So now let us look at the workup for these patients. The first investigation that I'll be running will anyway be a liver function test. And one of the pronounced findings that you will always get would be elevation of serum alkaline phosphatase. You see, in this disease, there might be a slight elevation of SGOT, SGPT. The values of SGOT, SGPT can be normal also. It's no big deal. It can be normal also. They are not very specific, or it could be a slight increase. But serum alkaline phosphatase will usually be showing up to a 4 times elevation, which is one of the pointers towards presence of cholestasis, as I've highlighted. I mean, whenever you have elevation of liver-specific alkaline phosphatase to more than at least 4 times or higher, it is suggestive of presence of cholestasis. As far as the values of bilirubin are concerned, well, like all autoimmune disorders, the values will keep on fluctuating. When I put a down arrow, I don't mean it will go lesser than normal. It will always remain elevated. It will always be more than normal, but the values will keep on fluctuating over a course of time. So obviously, if the values go more than 2, then you would be having a scleral icterus visible. Otherwise, if the values are on the lower side, then this scleral icterus may not be present. Now, since this is an autoimmune disorder, I will have to anyway run anti-mitochondrial antibody, anti-nuclear antibody profile in these patients. I want to tell you that in approximately 20% of these cases, the majority of cases, anti-nuclear antibody will be negative. But in approximately 20 to 50% cases, anti-nuclear antibody can also be present in these patients. But the more specific test that will help you identify this would be anti-mitochondrial antibody. At this junction, he would again try to trouble you with bit of physiology thrown in by incorporating the names of various mitochondrial antigens. And the names of these are given from M1 to M9. So don't be surprised that in multiple choice question, I'm using a different color to highlight it. In multiple choice question, instead of deliberately writing this word anti-mitochondrial antibody AMA, he might write words like anti-M9 antibody present. Or he might say that the person was subjected to a autoimmune panel and the report said like this. I'll just write the report before you. The report will say anti-M2, anti-M4, M8 antibody present. These are just ways that the examiner will try to upset your rhythm by just mentioning the names of the mitochondrial antigens. These are technically called as AMA profiles. So we can obviously do quantification and we can not only detect that antibody is present, it is absent, what is the titer. We can also work out the sub values of it, or I can say the various subtypes of it as well. So these are the names which I would like you to remember over and above the standard data. As in any liver disease, I'll be doing a coagulogram. So prothrombin time will be deranged, or he might write international normalized ratio, but these would be, I would say, later presentations. When you will be doing a complete blood count, you might actually notice thrombocytopenia. Why this thrombocytopenia is because the portal hypertension has already set up in the patient. You very well know that one of the early manifestations of portal hypertension is splenomegaly. And when the size of the spleen will increase, not only the size is increasing, but even the appetite of the spleen will increase, and this can contribute to development of hypersplenism. So once the spleen starts, causing a accelerated destruction, then even white blood count, TLC, can be on the lower side, and even platelet count can be lesser in the patient. So if you find platelet, that's the significance. I mean, in liver disease MCQs, you will find the hepatologist or the physician writing complete blood count with platelets. The significance is that if platelets are low in a guy with a liver disease, it means the fact that portal hypertension has set up, spleen has become bigger, the appetite of the spleen has become more, it has started eating up the cells. So that's why most of the time in investigations related to liver, even complete blood count with platelet count is mentioned. As I explained to you, in these patients, LDL cholesterol will be high all through. HDL values can fluctuate. So deranged lipid profile will be present in these patients. Then another important aspect which I want you to remember for diagnosis would be that before I do a liver biopsy, you see, ultimately, I mean, if I say primary biliary cholangitis, there's an inflammation, there's subsequently a ductopenia, all those pathological aspects which I explained in the initial part of the discussion, I need to be very sure about the fact that, okay, am I dealing with an extrahepatic versus an intrahepatic cause of cholestasis? So what should I do? Definitely is an imaging, that is ultrasound. So the objective of the ultrasound in this case is not to pick up PBC, but to rather rule out physical obstruction of the biliary tract. I want to rule out any extrahepatic cause per se. And once I have ruled it out, then I will be informing the patient that, sir, to be sure about our diagnosis, though we have a antibody that has been identified, we would like to go in with your permission for a liver biopsy. You need to take adequate precautions and ensure that obviously, the coagulogram is back to normal before you do the procedure, because one of the biggest complications of liver biopsy can be a development of bleeding. Now, once you get the consent, liver biopsy has been done. This is obviously the investigation of choice. It is the treatment that we need to consider. And I want to tell you that in real clinical practice, lots of time you may not get consent for liver biopsy, or maybe in COVID times, COVID patients were so many that we were not doing routine procedures. So we still have to treat. So what is that one molecule that I will write in anybody in whom I am suspecting a PBC progressing to primary biliary cirrhosis? I will be writing ursodeoxycholic acid, because I specifically want to neutralize the initial complaints of these patients, especially with respect to the pruritus. Now, if a patient is not able to tolerate UDCA, in those circumstances, we have an alternative new drug available by the name of obeticholic acid. The objective of both of them, some people are using both of them also. I would recommend you to primarily use UDCA. If there's an intolerance, then we can use obeticholic acid. And then I also taught you that these patients would be having extensive itching, though the main reason behind development of itching in these patients is excessive production of opioid peptides, and also the receptors for them are upregulated. But at the same time, the textbook says that bile salts may, he's not saying confirmed, but bile salts, because not getting excreted, may also be playing a role. So I would like to, in this particular case, sequester it. Right, so cholestyramine, as you very well know, is a sequestrant, and this would be again useful for management of the primary complaints of the patient. Antihistaminics, in fact, I would say most patients, when they will come to me or to you, they would already be abusing antihistaminics. He'll be taking everything. I mean, cetirizine, montelukast. This chap has tried everything, every brand available in the market, fexofenadine. So initially went to a dermatologist. So dermatologist gave him a short course of steroids as well. But then antihistaminics they have taken, but there is no improvement. So what can I do? I can be using a molecule that will neutralize those opioid peptides, and that is dronabinol. So from the exam perspective, most of the time, if they are going to talk about management of this case, two drugs that I especially want you to remember for this would be UDCA or dronabinol. And if it is not available, then you will have to use naltrexone. But then again, availability of these molecules is always a problem. Chemists are never going to dispense these kind of drugs without a prescription. So lots of time patients, they might, request you, over the phone saying, sir, I'm not getting it from a chemist shop. What should I do, etc. So the point is simply the fact that you will just say that, okay, against prescription only. But then as I highlighted, lot of time chemists, they do not stock these drugs on a routine basis, so may not be available. Another interesting fact which is given in the textbook for this condition is that if this is a serious worsening of the disease to prevent the progression of the disease from PBC, though it's a very gray area. I mean, I cannot say that, okay, after these many years, primary biliary cholangitis will deteriorate into primary biliary cirrhosis. But the textbook says that clinical studies have shown that in patients who are deteriorating in spite of the medical treatment, if you find that on a repeat liver biopsy the manifestations have worsened, then plasmapheresis can also be tried in these patients. Though the definitive management for this condition, if he says what is the treatment of choice, the definitive management will obviously be orthoptic liver transplantation, which is the main life-saving procedure when it comes to decompensation. I want to highlight this fact. Once the patient is going to go into the status of decompensated cirrhosis, there's a separate video on cirrhosis in which I've explained compensated versus decompensated, and the bottom line is if you have a portal hypertension, it is decompensated. So that's when we would definitely like to go in for a OLT for these patients. Among the differential diagnosis for this condition, by this particular point of time, I deliberately did not write it because I wanted you to think what could be differentials. Well, one is an important cause that has been discussed in the earlier section, that is autoimmune hepatitis. Then is primary sclerosing cholangitis and even sarcoidosis as well. You see, sarcoidosis comes everywhere. CNS manifestations, neurosarcoidosis, hepatobiliary, again sarcoidosis, non-caseating granulomas can be present. So, and I described granuloma as one of the biopsy finding of these patients. So sarcoidosis definitely makes an entry, but my thought process for any patient who would be having a waxing and a waning course of liver function test would be autoimmune hepatitis, then would be primary biliary cirrhosis. In contrast, primary sclerosing cholangitis would be having development of a beaded appearance of the biliary pathway, so it becomes easier to identify on a MRCP or on a ERCP. So let us now compare the manifestations of PBC with PSC. Now these are the two aspects that I was focusing on. One, you can notice that this would be a ERCP image in which how do I know it is a ERCP? You can see that faint shadow, the probe that is the endoscope that's going inside, and then the dye has been injected, and you can notice multiple structures which are present here, and therefore there's a beaded appearance that would come up. Subsequently, I can also say the fact that stenting of the biliary pathway will be useful for relieving the cholestasis only in primary sclerosing cholangitis, because in PBC the problem was predominantly intrahepatic. In fact, before we go forwards, just for the sake of completion, I can just draw a crude diagram here to highlight the difference in the pathology of the two diseases. You can take this to be a representation of the liver, then this is going to be the right and the left hepatic, common hepatic joined by cystic duct, gallbladder. And what I want to say is that in PBC, the disorder that we studied earlier, when bile is gonna be produced, then wherever bile is getting produced, surrounding that, there would be definitely fibrosis. In contrast, the topic that we are studying, the production of bile initially is going to be normal. The initial problem in these patients will be development of strictures, which will be multiple, and therefore I was talking about the stenting component being useful initially, or a balloon dilatation being useful to relieve the manifestations. But as the disease progresses, then even in the later part, even here, there would be intrahepatic manifestations occurring. So my objective from the two diagrams was just to sensitize you to the fundamental difference between the two diseases. Now, primary sclerosing cholangitis is mostly asked in the exam in pathology specifically because of this classical image that I'm showing you. And I'll just zoom it in for your convenience. I think you can pick up this onion skinning of the bile duct. Very characteristic that you always find. And in fact, this is one part of this particular topic that everybody is able to answer easily in the exam. So I'll just put it on record here. Onion skin appearance with respect to the bile duct on a liver biopsy is a characteristic feature of primary sclerosing cholangitis, and most of the time in image-based questions they would love to put any of the two images. Now, why does this disease develop? Then obviously it is also autoimmune, but do remember the fact that the textbook begins by saying that this is multifactorial. Autoimmunity is one of the components. In fact, in majority of cases, it has been found that though people might be having P-ANCA antibody, you see P-ANCA is even associated with ulcerative colitis, but they may not have primary sclerosing cholangitis. So he says the fact that genetic predisposition plays an important role in development of the disease. Along with autoimmunity, there's obviously an environmental antigen, then there are antibodies that are formed, and it's antibodies that are attacking the self. Apart from this, the risk of cholangiocarcinoma is dramatically increased with respect to primary sclerosing cholangitis. That is what I have said even in my GI discussions when I have spoken regarding inflammatory bowel disease. I have said that ulcerative colitis can be associated with PSC, and PSC can then be associated with the cholangiocarcinoma. And because of the association of PSC with ulcerative colitis is itself a pre-malignant condition and it predisposes to colon cancer. So in the exam, along with these images, again, a quick revision that you are already aware of, has been discussed in medicine, has been discussed in pathology: increase incidence of cholangiocarcinoma, increase association with colon cancer, specifically because of the association of PSC with ulcerative colitis. In both of them, the same antibody is playing a role, that is PNK. Let's look at the clinical manifestations, which are initially going to be pretty identical to that of PBC, but then the imaging will definitely play a role in this case. In PBC, I was doing an imaging to rule out the extrahepatic cause so that I could focus on the intrahepatic cause with liver biopsy. But in this case, definitely ERCP, MRCP would be the investigational choice, not a liver biopsy. Most patients initially will be having pruritus. That's a standard feature of cholestasis. I mean, anytime there is a cholestasis, you would be having pruritus. There would be icterus present, waxing and a waning course. The values may touch normal in between, and he might even describe mustard yellow urine. You very well know the fact that when you are having cholestasis present in a patient, then conjugated bilirubin is not getting excreted. And as a result of it, conjugated bilirubin is water soluble, blood soluble, and urine soluble. So once it starts coming in the urine, it would give that characteristic mustard oil. I would say not the texture, but the color of the urine would be pretty identical. So he can definitely write that. Then because of the fact that bile is not gonna be present for emulsification of fat, so you would be having steatorrhea manifestation. Vitamin A, D, EK deficiency will occur. Vitamin D manifestation manifests relatively early, especially Indian population is already less in vitamin D, so vitamin D manifestations appear relatively early. As a result of it, bone pain can be developing in these patients as well. So when you read the history, you might be actually wondering that is it PBC, is it a PSC, and he will definitely help you with the investigations also in the same question. So let's look at how would you arrive at the diagnosis in this case. The LFT of this patient is deranged, and when you follow these patients over a period of time, waxing and waning course would be present. Same statement of mine, serum alkaline phosphatase can be elevated up to 4 times of normal in these patients. Instead of serum alkaline phosphatase, he might mention regarding gamma GGTP, gamma glutamyl transpeptidase, that can be elevated in non-alcoholic steatotic hepatitis. It can be elevated in alcoholic hepatitis as well. So very non-specific test. And hypergammaglobulinemia. So if I do antibody profiling in these patients, IgM values will be elevated. Though I've written this IgM along with LFT only, I want to say that because this is an autoimmune mediated process with a genetic predisposition, so immunoglobulin M levels are grossly elevated. I'll be doing a coagulogram. So prothrombin time is standard in all liver diseases. I mean, ultimately prothrombin time is affected. Why? Because factor 7 has a short half-life. So therefore the PT of this patient would be deranged. As the cirrhosis component will supervene or intervene, the albumin values will begin to reduce. The antibody profile that will help me in picking up this disease is PNK. The only point I want you to remember is that PNK is found in only 65% of the cases of primary sclerosing cholangitis. Do remember the figures there. 65% cases of PSC would be having a PNK positive. And then remember another figure, 50% of these cases of PSC are associated with ulcerative colitis. The figures is new, but the data is still old for you. I mean, the figures is, the only point is he might mix and match these figures. So you just need to remember that if somebody is having PSC, 65 majority of patients are going to be having this antibody. And I mean, these patients could also be having a concomitant ulcerative colitis as well. The best way to confirm the diagnosis in primary sclerosing cholangitis would be answered as MRCP. We always give preference to MRCP over ERCP. In fact, Harrison has mentioned that You can go back to the textbook anytime, and while you are listening to these videos, and you would be in fact more comfortable, in fact, if you listen to me first and then you would listen to the video, because that's again a common query that comes, sir, should we read Harrison first then listen to you? So I would recommend listen to me so that you can, you know, assimilate the main points. So that when you read the book, no, lots of time in the book there might be so much of information given in pathogenesis of the disease, which is actually not really useful from the exam perspective, because those are all theories which are speculating why a disease is developing. Now, once we have identified this condition, we are able to see this very classical strictures. I can also say that liver biopsy can be done in these patients. The classical onion skinning that I explained to you for the bile ducts would be present, but there is actually no need for it as of now. It's rather imaging that would be sufficient for diagnosis. For treatment, I will recommend a balloon dilatation if feasible, if the facilities are available, ERCP, with we can dilate the strictures. Now the dilatation of strictures can be either with help of a balloon, or it could be stenting, depending on, you know, if it's a minor stricture at one point, initial part of the disease, maybe stenting can be done, but subsequently balloon dilatation will make more sense, because this patient would be having multiple strictures at multiple sites. Over and above this, if he says what is the definitive management of these patients as they become decompensated, orthoptic liver transplantation is the mainstay of treatment for these patients. So the indications for orthoptic liver transplantation is increasing gradually. We initially talked about fulminant hepatic failure as an indication for orthoptic liver transplantation with a MELD score values. Then I spoke about orthoptic liver transplantation in alcoholic cirrhosis patients, right? And then PBC and PSC are again indications for going ahead with this procedure, including autoimmune hepatitis. So in one of the lectures subsequently, what I'll do is I'll compile a list where, or you can do this by yourself also, that you can just write the word OLT, and the indications and the requirement for these will keep on increasing. It could be autoimmune disorders, it could be genetic disorders with decompensation like Wilson disease. So it's a whole list that definitely will come up subsequently. But the message is that if you get the pathogenesis of the disease correct, along with couple of facts from pathology, couple of additional facts that I have mentioned here, especially like opioid peptides being responsible for pruritus, you would be on your way to crack this topic. I would rate this topic PBC and PSC as a relatively easier part of liver per se. So thank you so much for hearing me out, guys. Keep hammering, keep the focus, and I'm sure all of you would come out with flying colors. See you on the other side. What I mean by see you on the other side here is getting a rank. Thanks.